And thank you very much for inviting me. I think this is a good platform to show what we do in research and hopefully see the light on some of those research findings to be implemented in the community. I'm happy to be the last person to present this year, so we'll leave you with a good sense of what we've been doing this year, and ready to show you like what's the program if you haven't heard about it, and what's the value to keep it around for many years to come. So I want to start with the traditional land acknowledgement, like most of you are working in the same land. So I want to respectfully acknowledge that UNB stands on the unsurrendered and unceded traditional Willistic Way land. And it's a pleasure for me to play and eat and work on this land. So the problem that we're going to talk to you about today is the fact that although we all know that exercise is good for your cognitive health, motor function, emotional function, intellectual function, and so much more, we know that if people do exercise, it will reduce the risk of the risk of many chronic conditions, but one of them that is really close to my heart is to keep people at home as long as possible. There's a lot of risk reduction or cost reduction if you are regularly active. But the problem is that most Canadian and most human really, including people in New Brunswick, don't exercise enough. So more than half of our population, adults and kids, do not do enough exercise to actually get all those benefits. So it's a huge problem that we deal with, and the society that we live in, where sedentary behavior is the way to go, it is a problem that is really hard, and we're trying to address that in many ways. The second problem that I want to talk to you about is falls. So although exercise is really related to different chronic conditions, falls is something that is interesting and important, and for many reasons. Each emergency department visit costs a lot, and not the first one to tell you that. So the average is $304 every time you go to the ER. And falls is the main reason why older adults will go to the ER. Another statistic that is interesting, and I don't want to bug you too much with the numbers, but we tend to see a lot more one-on-one. So a lot more people on 1,000 residents will see the ER in a given year, which is alarming because not only they cost a lot, but we have more than what we would like. Daily, like so today, or if you'll only look at yesterday, 8 people is the number here. So 8 older adults are admitted to the hospital because of a fall-related injuries. The good news is most of those falls are preventable if we do many different things to avoid them. And we'll talk more about this. These are numbers that you would have heard before. I find that when it gets too big, I get lost. It's 250 million a year, a big deal. And when it looks in millions, based on my scale, it sounds like a lot, but I like to use it as falls only cost 7% of the whole health budget. That's how much it costs in direct and indirect costs. And we tend to think that it's only if it breaks something. It's only, I guess, injured falls, but it's all falls. So having a fall, there's a recent study that showed that falls, whatever you have an injury with it, or you just had a fall, they'll cost a lot to the health system. So I think this is a number that we want to keep in a sense that it affects a lot of people, 8 people a day in our province, which is a lot for the small province we have. And it does cost 7% of our whole health budget, which is, I think now sounds more bells for me. I have always a question, why focus on falls? I don't think we focus on falls. I think falls is one outcome. So it's not only about falls. And I think like, you might recognize some of those chronic conditions that are listed on the right. Those are the most prevalent chronic conditions that we have in our community. And if you look at the data, there'll be like 28 out of those 32 that could be impacted if people would be more active. So although people were targeting falls in the case of Zoomers in Balance, they are doing exercise. So not only are we affecting the risk of falls, but we're now like affecting all of those chronic conditions that could be like to some extent help with the fact that they become active. So falls is only an outcome. Another thing that I'd like to mention is that we tend to think that it's all about seniors. So as soon as you get like older, those are ages in the blue line here. There's falls that happen at every ages. The big difference is that the consequences of your falls are different. So when you're older, the consequences are more, but there's still 21% of us, or 24, like about 20% of adults altogether that will fall before the age of 65 every year. You laugh about it, you get up, and then you go on with your day. When you get a senior, it's a bit more complex, but falls not only happen after your age 65. The problem with that is the fact that, yes, we're aging and there'll be like more and more people age over 65 plus. So although you fall at different ages, the consequences that I talked about, like the fact that you're going to have an injury and not be able to live in your house anymore, are going to happen more and more. And that's why I believe that we need to focus on falls, although you have some other advantage of being active. So what's the best way to prevent falls? We can have a list. I put like a few here, but there's many things you can do. You can have like decluttering your house. You could have like putting rails here and there. You can make sure that you have good lighting, all of that. But when you look at the literature, what's the most important one is to exercise regularly. And I'm not saying this because this is my field of research. I say this because that's what the facts are saying. And that's why I push for this type of intervention. And then when you do actually do physical activity, you're reducing your risk of falls if you do exercise by 51%. And if anybody here in the room is an epidemiologist, you'll know that one factor associated with 51% less risk is huge. It's about the same what we have in terms, it's not even the same that we have for the relationship between smoking and having lung cancer. So that's how big the association is between being regularly active and reducing your risk of falls. So this is huge for public health. And then when you wondering like what and when, because we're a bit victims of our success in exercise, where everybody knows that they should exercise and everything you do is good. But that's not the case. There's exercise that are better for some of the chronic condition that I listed before. And then some of the exercises are better when you really want to target the falls. And when you look at the literature, the best review we have on this subject was including 13,000 people. Good studies, randomized trial. We have so much information about falls. The problem is that we don't apply that knowledge in our day-to-day activities and communities. Out of those 59 studies with high certainty of evidence, there was 3 things that those programs need to have. It has to be offered all year. It has to be offered 3 hours a week, and it has to challenge balance. So that removes all the activities that are done on a chair to reduce risk of falls. That would not get into this recommendation. So those are the 3 main key that you want to do. So you will notice that we're not saying you should do we should do walking, we should do Tai Chi, it doesn't matter how you call the activity, as long as it's offered 3 hours a week, all year long, and you challenge balance. And people will say, well, I can't offer 3 hours a week. No, you can probably offer twice a week, but recommend how you could do the extra time on a different time or different places. That's where maybe the technology comes into play. I always refer to the fact that my goal is to give 5 to 10 portion of fruit and veggies to my kids. It doesn't mean that they will eat it. They might give it to some other people. They might hide it somewhere. But my goal is to offer what's best. And what's best for fall prevention when it comes to exercise is those 3 criteria. So now, like, you go to like Zoomers and Balance. So it's a typical story. We did randomized trial. We tested in different contexts. We got the same outcomes. Everything goes well. We scaled up across the province. And now we're at the point of like implementation and finding a way to sustain these programs. If we don't pass that red line, then we will just be a typical story. So if we do find partners to continue this program, then we can get to like implementation. And implementation meaning that we understand more why in the region of like, I don't know, east, northeast, they can't figure out a way to offer the program. Why? So we're looking at barriers and facilitators to continue to offer the program. And sustainability is all about making sure that what we offer in 10 years is the same as what we offer here in terms of like the content, the fidelity, but also like finding long-term funding and a structure that makes sense in our context. It is sadly estimated that there's every year $85 billion wasted in health research, meaning that we do all that work, the first 3 steps, and we stop there. And then we hope that someone like people sitting in this room will find this information and implement this in their communities or in their program or in their stakeholder capacity. The good thing is I'm pretty patient and I still have some years to go before I retire. So like it takes 17 years before we actually can get something to be implemented long-term in the community. So it's not something that happens overnight, but it's something that we need to be patient and still working on why is it not passing that red bar. So for some of you that don't know what the program is, it's a program that is an exercise program that is offered ideally by a peer-led exercise by older adults themselves. So it's a program that the participants are age 50 and plus, and the leaders are also age 50 plus, but they are volunteers from their community. We offer the program 3 times a week, all year long, and we challenge balance. That's something that happened over time to make it evidence informed. It's based on the world guidelines for fall prevention. So what we offer in Zoomers is what's the best we know about offering a program in the community. The main goal is to reduce risk of falls, but obviously there's evidence that we do improve different health outcomes and functional outcomes. We did demonstrate that with our randomized trial. But it's not a surprise because we know that if you offer, you will have the outcomes. Our goal is to have a standardized program, free, if possible, in both official language across Canada. We are, I'll show you where we are, but it is pretty much implemented now. Who is coming to the program? We're focusing on the low risk. There's many reasons for that, and we could go to intermediate and high risk if we were to like continue the continuum of care. The low risk are the main target because of 2 reasons. First, we can increase the functional capacity of these people so they fall less now, but also less likely to fall later on, and also because of the peer leader model. So those peer leader model are not a physiotherapist or a physician or a nurse. They are someone with no big background in healthcare whatsoever, or maybe, but it's not required. They get a 2-day training, and so like sending them with high risk of fall would not be the way to go. To do this, we do partner with health professionals with some partnership with Occupational Therapy Association and also Physiotherapy Association, so they can offer Zoomers with less training, and then because it does fall into their scope of practice. You might wonder who comes to this program. So this is just a snapshot of like one little study that we've done a few years ago now, where it shows you like who is on, who comes to this program. So although it's offered to age 50 and plus, the average is about 67 years old. And you can see the demographic is really similar from online or in person, something that I didn't mention yet. Those classes are offered in person, they're offered online, meaning that people can log in and do the program. They can also use pre-recorded videos, and we also developed like now an app that could be like a tool. And you might wonder like, oh, technology here, we're talking about seniors, but there's a lot of variability in terms of like what the technology literacy of seniors, and there's many interested in this option. It's the only option. We're offering different options. So not many differences between online and in person, which was interesting at that time. So what are the evidence that this program is working? We did a randomized trial back in, that was published in 2021, showing like the evidence that when you do the program versus non the program, what can you see in terms of risk of falls? Falls are really hard to capture. First, they don't want to report it. It doesn't count if it's not hurting. Especially male will not report any falls. It doesn't count. And so you almost have to have like another way to capture falls, which we do, but it's not something that is captured in a 12-week program or like a 6-month. It's something that is done long-term, and I'll show you what we do with this. We compare online in person, no difference is as good, besides the fact that the social activity or the social component is less interesting that way. We also like now are able to test people online. That's the last paper that we've done with this group, where we can actually like evaluate the change in the risk of falls by doing it online, which is an add-on to what we can do. At first, we were in St. John, as the person said at the beginning, and we did the RCT in Fredericton, so we can have like what I call at the time like Zoomers version. And now like we've been up around the province, and I'll show you where that is. Just an example of physical results that we observe in the study. So when you do like the pre-tests, so like you have like here we have like a pre-testing. So we ask people in 30 seconds, how many times can you stand up from the chair? And at the end of the program, this is only 12 weeks, They have 3 more, and you might wonder, is that interesting? And it is interesting because of 2 reasons. First, to be functional, you would like the norm actually is here, like 11 to 18. So you're pushing people further in the average that you would like to see. The second reason why it's important, it's because when they have a better chair stand, they are less likely to fall in the future. So that's like doing inference for the future. The third reason why it's important is that because the average person in their community will do this movement about 65 times in a day. Every time you go out of the bathroom, every time you go out of your car, dining room, you do like a squat, a chair stand, and you don't notice that you're doing it. So getting better at it makes you more likely to stay home longer and less likely to fall. We've done online testing as well, and we see the same results. On the right side here, the control, you see that when people don't do the program, not surprisingly, they don't change. Oh, I'm having trouble with my pen here. Get back here, get rid of this, and we're good to go. So there's many testimonials that will come from the public that do the program. I have often have like emails saying like this program is a life-changing. It's free, so it's less money. It's fun. It also like improve other things. There's only 3 testimonial that I put in, but there's many out there where this program is actually going in the community and at small scale, and people feel invited. It's not enough to make to the next point, because that's what it was before. When I took it over in 2012, this program was fun and people liked it. But then we attached the data to show that this is more than just fun and people like it. It's actually working. We did scale up with the help of HSPP funding. So this is to give you like a sense of how many people do this program. So in 2023, we were talking about like 3,000 people. That didn't really include the fall session. So in 2024, this is 2023, we're about like 3,500. And this year, I just look at the data for including the winter of 2024, and then we will have more than 5,000 people in the program this year. This is where we started on the right side on the top, and then it's spread across the province here on the left bottom. Whether you see a purple or the dot, it's because we have participants and leaders. When you see a black, it's because we have people in the program online. And then the green is we have leaders that are trained right now that will eventually deliver in person. We are also delivering across the province. We're not taking care of the operation there. We're being a consultant for other communities who wants to implement Zoomers. It's currently in Alberta, in Ontario, in Nova Scotia, and we're about to implement it in PI. And the important thing here is we're not trying to tell people, whatever program you have, shut this down, we'll give you money to do a new program that works. We say, do you need a new program? If so, let's go with Zoomers. If you have a program and you want to make it more evidence-informed, then the money is there to help you change your program to make it evidence-informed. Myself and colleagues have a good funding right now that's called AIMS. It's coming from the Canadian Institute of Health Research. And the goal is to understand why. The first A is adapt. So exactly what I was saying, like we take programs that exist that have solid funding and we try to make it more evidence-informed. The second A is attract, and we're trying to attract people that are other than white Caucasian women. If you look at the descriptive of our population, it's most of the 88% would be like women, and most of them will be white Caucasian. Why? It's not a problem that is different in New Brunswick than it is in other provinces, in other program, but we're trying to understand why. The implement is exactly implementing Zoomers in other communities that do need it. And then we're not after showing that it reduces their risk of falls anymore. We're after showing why we are able or not able to implement a program such as Zoomers. Why is it hard to get funding to do this? Why is it hard to be introduced like in rural communities? Why that we're after. And the last one, the S, is trying to understand like programs that did sustain over time. Some of you might be aware of the program called Otago. It was started in Otago, New Zealand. It's still around. It's an evidence exercise program that is offered. Why were they able to sustain over those years? So that's the CIHR funding we have until 2028. So in terms of sustainability, Zoomers has in terms of the number of people that were in the program were limited before we took over in 2018, 2019. And so we've been increasing more and more the number of people that come to the program. The problem right now is that we have less resources. So we were running about 225,000 a year during HSPP, and now we're at $100,000 a year. So we need to create more capacity, but we have less resources. I always say that without the in-kind contribution from UNB, this would not be sustained. But for now, like we have money coming in from Trauma NB and also MetaV Foundation. And then we are hoping to get more in the future, because if not, it will collapse. Because right now it is managed at UNB. And then as long as we have aims, I kind of need to keep it alive. So I put a lot of in-kind contribution, but after this funding is done, it is not the responsibility of university to sustain an exercise program in the community unless there's research being done around it. So it will collapse eventually if we don't have maintained funding. So is it cost effective to do this? And there's a big systematic review that was done in this subject. And what they found is there is moderate certainty evidence that fall prevention exercise program are likely to be cost effective. And you see like it's pretty vague. And the reason is that it depends on the model, it depends on the expenses, it depends on the risk. But more, I mean, generally speaking, there's evidence that it is cost effective. And the question that it comes more like in terms of like local is Zoomers worth the price. Really, that's what it comes to. And when you look into like the data, like so I looked at the data in 2023, and it would have cost about $34 a person to do 12 months of exercise, and that's really important. So the person has access to the program 3 times a week for the whole year. Normally, people will have access to once a week, or they'll have access to 12 weeks or whatnot. This is $34 a person. That's not a lot of money. The average total cost for a fall is $62,000. So really, it costs $34 a person, but one person that falls will cost us $62,000. So I think the math is pretty easy to do in terms of like, is it worth the price? So the question becomes like, can Zoomers in balance reduce 2 falls per year? And if that's the case, then it's worth the price. So the way that we follow falls, it's within the NB-IRDT. We're looking at the data now, 5-year follow-up. So we have 931 people that will be matched with up to 10 people that were not involved in the program of Zoomers in the past. And we're looking at if they were less likely to fall, if they were less likely to be hospitalized, if they were hospitalized, were the length of stay at least be lower, and are they less likely to see their physician? So but the first point is the one that we will actually get an objective value that if the program actually reduces the risk of falls. I'm hoping that the 5-year will be enough to see something, because the people that come to Zoomers, the same way that anybody that goes to community program, they are likely to be more active, more interested in their own health, and they might actually, like, for example, call their physician once a year to make sure they have a follow-up appointment. But that is one key element that we have in the Zoomers, is that people were offering a Medicare number, and now we can look at the administered data to see the benefits of the program and put numbers on the value of this program. To sustain the program, we need training, and that is done through FNB, Fitness New Brunswick, in the province. We need management, and I'm having conversation, I'm going to say like every week, if not every day, about organizations that their mandate is to offer similar programs so they could add to their current offering. There's actually like more interest than I thought there would be, so I'm happy to see that. And then we need to go after funding so we can actually maintain the operating costs. And then I'm sure hoping that we'll be still involved though where we need to be involved, which is continuing the evaluation. It's not about showing that this program is good for XYZ outcomes. We know that. It's more so to understand like what makes it continue, what is hard, why there's community that don't want to have the program, how to make sure that the program is still offered the way that it's supposed to be, and all of these things. The human resources for doing this program is about 450 grand a year, but the operating cost is really low. So really what costs a lot of money in this program is to the management. So like taking the registration, finding their leaders, like finding the location that they offer. It's more so about human resources than it is about like a cost. I didn't say that, but there's no equipment at all being required for people to be in the program. So it is an exercise program that is totally based on using your own body to do this. With this amount of funding, we would be able to like reach at least 15,000 people per year, and we would have unlimited capacity that we can do using technology. And then all of this would be about less than $1 per week. So we would be about a $50 per year per person to have access to a program. So the reason also I think that this program is worth pushing for is the fact that it integrates the New Brunswick landscape. It does apply, or it does add to what's currently offered. It's not duplicating what's offered. It adds to the current initiative offered in New Brunswick, such as Home First, Nursing Home Without Walls. The aging, it fits well with the aging strategy and also age-friendly communities. There's many support interests from different communities and also government departments. So I think there's something here to grab on so it doesn't leave before we forget it was that good. So I'll stop here and I'll take your questions. I put my email here on the right bottom, and feel free to email me after the talk if you have like specific questions. I'll be happy to answer them. So thank you.